hyperthyroidism is 10 times more common in women than men and are the second most common endocrine disease behind diabetes. Thyroid disease is a general term that refers to overactivity or underactivity of the thyroid gland. In this two-part lecture series, we'll review hypothyroidism and hyperthyroidism. The USPSTF neither recommends for or against routine screening of non-pregnant, asymptomatic adults due to insufficient evidence regarding the balance of benefits and harms. However, the American Thyroid Association recommends screening women over the age of 35 every 5 years. Hypothyroidism is an underactive thyroid disease. Although the exact prevalence is difficult to quantify, it remains one of the most common conditions seen in primary care practice. The most common cause of hypothyroidism in the U.S. are autoimmune processes. For these reasons, rates are higher among women with diabetes, rheumatoid arthritis, pernicious anemia, lupus, and other autoimmune disorders. Hypothyroidism is further categorized as primary or secondary. Primary hypothyroidism is a result of conditions that inhibit the thyroid's ability to synthesize or release thyroid hormones. These include chronic autoimmune thyroiditis, also known as Hashimoto's disease, congenital hypothyroidism, postpartum thyroiditis, inadequate iodine intake, or iatrogenic causes such as thyroidectomy, anti-cancer treatments. Medication can also affect the thyroid's ability to produce adequate hormones. Medications that decrease TSH secretion include dopamine, metformin, opiates, or glucocorticoids, a class of corticosteroids. Lithium can decrease thyroid hormone secretion. Medications that can increase thyroid hormone metabolism include rifampin, an antibiotic that treats TB, or phenytoin and phenobarbital, anticonvulsants. That concludes the review of primary hypothyroidism. The secondary causes of hypothyroidism are conditions that affect the pituitary gland and hypothalamus. These include pituitary adenoma, surgery or radiation treatments of the pituitary or hypothalamus, sarcoidosis, or other autoimmune conditions, subarachnoid hemorrhage and Sheehan syndrome, pituitary gland necrosis subsequent to severe postpartum hemorrhage. Symptoms of hypothyroidism correspond to disease severity, as evaluated via serum lab testing in clinic. The symptoms may include fatigue, cold intolerance, bradycardia, reduced exercise capacity, muscle weakness, dry skin and hair, weight gain, sleep apnea, infertility, miscarriage, impaired memory, constipation, depression, myalgia, muscle pain, arthralgia, joint stiffness, and irregular menses. Overt and subclinical autoimmune hypothyroidism are commonly seen in women as they age. The generally accepted definition of overt hypothyroidism is having a subnormal T4 and a TSH greater than 10. Subclinical hypothyroidism is defined as an elevated TSH and a normal free T4 concentration. Women with subclinical hypothyroidism generally don't have symptoms and they feel well. This is because their free T4 value is normal. However, women with overt hypothyroidism generally have a wide variety of symptoms. Treatment of hypothyroidism is effective and safe. The gold standard for treatment is levothyroxine sodium, commonly known by its brand name, Synthroid, at a starting dose of 25 to 50 micrograms, although expert opinions vary, as some recommend higher starting doses in younger women. Thyroid hormone replacement is usually lifelong and should be monitored in clinic to ensure the individual remains euthyroid by lab standards. Euthyroid simply means an individual's thyroid labs are within the normal range. Side effects of levothyroxine can include nervousness, palpitations, and chest pain. Women over the age of 60 should be started on a lower dose to prevent the side effects. TSH levels take about 4 weeks to adjust after every dose change, so testing should be done no sooner than every 4 to 8 weeks, and then annually once normal TSH levels are achieved.